Hello, everyone. My name is Dr. Nathan Zasler, and I'm very happy to be here today to serve as moderator for Dr. Stephen Laureys' presentation and webinar on functional brain imaging and disorders of consciousness, clinical practice, and forensic arena. What can be said with confidence? Dr. Laureys is a prominent neurologist and neuroscientist known for his work in the field of consciousness research. In 2006, he founded and headed until 2020 the Coma Science Group with the GIGA Consciousness Center that he founded in 2014 at the University of Liège in Belgium. Most of his research work is devoted to the study of alterations in consciousness in patients with severe brain injury, as well as during anesthesia, sleep, meditation, and in the hypnotic state, as well as during other conditions. Dr. Laureys is the author of over 550 scientific articles. He is winner of numerous scientific awards and is undoubtedly one of the world's leading specialists on the issue of altered states of consciousness. He is currently chairholder of the Canada Excellence Research Chair in Neuroplasticity at CERVO Brain Research Center, University of Laval, Canada. He is an invited professor at BIDMC, Harvard Medical School, and honorary research director at the Belgian National Fund for Scientific Research. He is also co-founder of Brain NM Neuromodulation Clinics, Antwerp and Amsterdam, and MindCare International Foundation. We're very, very honored and pleased to have Stephen present to us today and look forward to the presentation.
Thank you so much.
It's all yours.
Thank you so much, Nathan. It's a pleasure being here. I thank you for this kind invitation. Also, special thanks to Carolyn Schnackers, very active within the International Brain Injury Association. And for those who are interested and want a bit more in-depth information, Carolyn and I just edited the 3rd edition of the book Coma and Disorders of Consciousness. So, Nathan, thanks for this introduction. It's a challenging title. What can we say with confidence when it comes to disorders of consciousness? I think consciousness is one of science's biggest mysteries. We shouldn't be too arrogant there. My passion is to use functional neuroimaging, all machines we currently have, to reduce our ignorance when it comes to understanding thoughts, perceptions, emotions. And as you mentioned, I'm doing that with the teams both in Belgium, Canada, looking at pathological modifications of consciousness, and that's the topic of today, of course, coma and related states in people who survive intensive care but take more time to recover consciousness, but also at pharmacological changes such as the effect of anesthetics, psychedelics, and then finally physiological modifications of consciousness, as we all know them when we lose consciousness falling asleep or dreaming, and also hypnosis and meditation. I started my career, entered medical school in 1986 and then graduated in 93, while from the start actually spending time in research labs. And my first challenge was to understand pain, neuropathic pain, and that was through the study of an animal model. Here you see a rat with microdialysis probes into the brain, and how a lesion of the sciatic nerve is changing the neurochemistry of the rat's brain. That was while I was at university in Brussels. And from the start, it was quite frustrating to try and measure pain in this animal that, of course, couldn't communicate what it was perceiving. And that still is the frustration we are faced with today for those of you who are dealing with patients who are comatose or suffer from these disorders of consciousness, where, again, we try to make the best possible inferences we can based on behavior, a motor output, when it comes to their personal subjective experience. And that is actually the same for the big question in humans, when is consciousness arising? And I gave a TEDx, you see here, with my youngest boy, a baby. What can we say about the possibility of perception, including pain perception and conscious awareness in newborns? And it's also the case for non-human animals. And I'm very happy to share that from a neurological perspective, of course, there is no reason to believe we are the only species with consciousness, and I co-signed the Cambridge Declaration on Consciousness in human and non-human animals. Again, being faced with that big challenge that we know in disorders of consciousness after intensive care, that is, we can't communicate with them, but that doesn't mean that they are completely insensate. So how do we do as physicians, as caregivers, faced with, as said, science's biggest mystery? Is this patient conscious, when we have no universally accepted definition of what consciousness is? So very, down to earth, in a pragmatic way, we will reduce the complexity of what we call consciousness to two main components, and that is the level of consciousness we call wakefulness or arousal, which is quite straightforward to assess at the bedside, looking at eye opening. And then there's the content of consciousness, or awareness of the environment of the patient, of patient's self-consciousness, stimulus-independent thoughts, which is more tricky. And that we will basically assess by making inferences, again, based on verbal or non-verbal reports and response to command, and looking for non-reflex behavior. So in this scheme, level versus content of consciousness, we can all appreciate that consciousness and conscious awareness is what we lose when we fall asleep. I hope it won't happen during this webinar, but of course, when our level of consciousness, arousal, wakefulness goes down, at one point we lose awareness of what's happening around us. And we already have here a notorious exception, which is REM sleep or dreaming, where from the outside, the subject, the patient, looks unconscious, asleep, and yet, of course, is having these very vivid oniric activities we call dreaming, and especially so in lucid dreaming, which is the fact that you become aware that you are dreaming and are spending time in REM sleep, yet can decide your actions. Now, coma is defined, as you know, by a patient who can no longer be awakened. So will never open the eyes, even when we stimulate the patient with intense auditory or noxious stimulation. And hence we say that there is no capacity for conscious awareness. The same for pharmacological coma or general anesthesia. And then there is this very strange dissociation where patients survive their coma, open the eyes, but only show reflex movements. And that was coined persistent vegetative state. It is a term I do not like because I think it's pejorative. We're not going to compare human beings with vegetables. Vegetative state is now recoined unresponsive wakefulness. wakefulness, which is a more neutral term. We put a lot of effort together with the European Task Force to propose this new name, and this is also now adopted by the American Academy, both of Neurology and Neurorehab. So unresponsive wakefulness, because patients are awake after coma, open the eyes, but do not respond to a simple command. We have other examples in neurology, such as epilepsy, sleepwalking, where patients again show motor behavior, that's not reflex, but fail to show response to command. And then there is this very important entity defined by Joseph Giacchino, minimally conscious state, or maybe we should say minimally responsive state, because that's again what we are confronted with. It's motor responsiveness, where we subcategorize this MCS entity into MCS minus, and these are patients who show non-reflex movement, such as a patient who would smile when there's a family member in the room, and that's all you got, and it's not present when it's another person, or would follow with the eyes when, for example, there's a family member moving from left to right, or would orient towards painful stimulation. The next is MCS plus, where patients do show reproducible response to command, but not in a way we can exploit that movement into a functional communication yes/no code, as is the case for locked-in syndrome. As you know, these patients, typically after a vascular brainstem lesion, but it can be any cause where there is a disruption of the motor pathways, basically having patients after coma awakening fully conscious but paralyzed. And for neuroanatomical reasons, they can only communicate their thoughts and wishes through small blinks or movements of the eye. So we have this interaction between the level and the content, and I think a big challenge is the dissociation we've historically seen since improvement in intensive care in so-called vegetative, now called unresponsive wakefulness. Now, what can neuroimaging tell us about these very challenging patients with disorders of consciousness with unresponsive or minimally conscious states? In the 90s, when we started this research, and we were very few to do so, it's together with Nicholas Schiff in New York, Adrian Owen at the time in Cambridge, now London, Ontario, it wasn't very clear whether consciousness was just dependent on overall brain activity, or whether there were some parts that are more important than others for you to be conscious. So we used what is still is actually the most direct marker of synaptic activity, and that is radioactively labeled glucose. So using positron emission tomography and metabolic FDG imaging, this is a normal, awake and aware brain, a full 100%, colors are artificial of course, representing the energy use of those billions of neurons. And your brain is using more energy than any other organ in your body for its weight. If we start with the extreme, brain death, which is the neurological redefinition of death, we see the empty skull sign. Okay, there is, even if we turn up the volume, nothing to be seen inside the skull, only some activity you see there in the skin, but not in those billions of neurons. So brain death is death, and this is of course a reassuring image, very important in the whole discussion on organ donation. When you go to sleep, in deep sleep, you see a massive global reduction of about 60% of normal waking values. And in REM sleep, something paradoxical happens. You have near normal activity, and that is, of course, when dreaming is occurring. When you're knocked out comatose with anesthetics, you see again this massive reduction. This is an image using propofol. When you stop the drug, overall brain activity resumes to full normal levels. So this could reflect that, yes, consciousness seems to critically depend on overall brain activity. Well, I think what we and the team have shown is that through the study of coma and vegetative unresponsive wakefulness, especially in those who do recover, we saw this is not the case. Patients who are comatose or vegetative unresponsive have again this massive global reduction, but when they do recover consciousness, we don't see the whole brain recovering to a full 100%. In other words, you do not need your whole gray matter to be conscious. And we've been repeatedly publishing on this finding that there is this global neuronal workspace, frontotemporal-parietal, that seems to be critical. And that information is then being used through AI-based classifiers to help us clinicians reduce the uncertainty whether or not the patient is unconscious. You see here those results, and the network. This has been shown since the late 90s. You see widespread both on the convexity and the midline core. And what seems to be critically important is how these cortical areas interact, the functional connectivity within this network and with thalamic nuclei. And the same holds for the other situations of people who show motor responsiveness that is non-reflex, but fail to show answer to commands such as complex partial seizures, absence seizures, or sleepwalking, as you can see here. And now we have the tools to look at the functional connectivity within that network. This is a paper by Melanie Bowley, at the time a PhD student, now a professor at University of Wisconsin in medicine, using dynamic causal modeling and event-related potentials. So we present auditory stimuli, high-density EEG in intensive care. You see 256 electrodes. And then we look at the interaction between, in this case, the auditory areas 1 and 2, and then that higher order awareness network I was mentioning. And it turns out that for you to be conscious of, in this case, an auditory stimulus, you need a top-down feedback connection, direct arrow, and that was not present in any of the patients we studied in coma, in unresponsive wakefulness. And this, of course, is helpful again for clinicians and works at the single subject level. So over the decades now, we have been repeatedly publishing with the team and the current co-directors of the Coma Science Group that I founded, Olivia Gossery, Aurore Thibault. You see here how functional imaging has added value when it comes to the diagnostic uncertainty of patients suffering from chronic disorders of consciousness. And there is this important category of patients where at the bedside we think there's nothing going on, there's no consciousness, but the neuroimaging results tell us otherwise. This is a recent paper from Annals of Neurology, and you see the cover image where we show, again, functional connectivity with high-density EEG. You see in the alpha band on top, in healthy controls, this widespread communication between areas and this breakdown in unresponsive wakefulness syndrome, and then the intermediate result in MCS patients, and kind of the opposite image for the slow pathological delta band. But then there is this category, you see MCS star. What is this? This is patients where we think there's nothing based on bedside assessment. We consider them vegetative, now unresponsive wakefulness, yet you can see that the connectivity studies show, well, there's more going on. And we see the similar image on the left in the FDG PET studies that we simultaneously recording these patients, basically being sent to our centers from all over, sometimes also within legal contexts or just referred by physicians, because there is uncertainty when it comes about the diagnosis, but that's what we will see also the prognosis. And then you see again there that there is this massive reduction when patients are unconscious, very different from healthy controls or locked in. MCS is intermediate, and then the MCS star are patients where, well, they come in with the label unresponsive, but neuroimaging shows us that more is going on. How many patients? It's very hard to say, because we have, of course, a inclusion bias. It goes from 20 up to 40+% of patients where, we made the diagnosis of vegetative unresponsive. And you see, we also do structural and functional MRI. And using functional MRI in these patients, we could even push it to the next question. So once we see that there's more going on, we had these very exceptional patients where we can use the fMRI to establish communication. So this was the initial work we did with Adrian Owen, the science paper in 2006, where we basically do the same as what we do at the bedside. Our awareness test is very simple. It's actually the same as we did as physicians in ancient Egypt, like squeeze my hand. Is there a response to a simple motor command? But of course, patients can be paralyzed, and so we can miss things when we base our diagnosis on bedside behavioral assessment. So here what we do is putting the patient in an fMRI machine, doing actually the same as we do at the bedside, which is, move your hand, but we don't look at the hand. We look at the motor cortex. We asked a number of questions. It turned out that asking people to imagine playing tennis was a powerful one. The other question was imagine to walk around in their house, because that activated the hippocampal areas. And then we had this young boy who was sent to my center in Belgium with the label vegetative, and we put him in the fMRI, and we see that he is not, that he can actually hear and understands, and does what we ask him to do in this very special imagine tennis, imagine navigating paradigm. And we explain him, if you want to say yes, do the motor imagery. If you want to say no, do the spatial. It's a very, very complex task for patients, whereas you see after traumatic brain injury, there is severe cortical damage and secondary hydrocephalus. Yet, as you can see, this fMRI signal was decoded correctly. Question 1, he's saying yes, doing the tennis. Question 2, he's saying no, hippocampal activation to the imagine walking around in the house. Question 3, saying no. Question 4, saying yes. Question 5, saying no. And then question 6, I was probably just exhausted. We can't decode anything anymore. So this is a proof of concept that yes, we do have patients, despite the label vegetative unresponsive wakefulness, where neuroimaging shows us not only they're conscious, but actually is permitting us a way to ask questions. And these were really simple questions like, is your name Alexander? Is your father's name Thomas? We knew the answers to these questions, but of course, what we really want to do is to give these patients a voice, to know what it is like to be in this condition. And I'm very much convinced that we will have cases in the near future where these technologies will be employed. And of course, then we need to discuss as a community, together with the engineers, with the bioethicists, and us physicians, caregivers, how do we interpret this? This is terribly hard to do with the fMRI. We actually have a failure ratio of 40%, despite the fact that we do this now for many years and have a lot of expertise. It's terribly difficult to have good quality data because we're very sensitive to movement artifacts. And that's why we use and put a lot of effort in EEG-based brain-computer interfaces. And we work with the company GTech. It's actually the first and only commercially available BCI. It's the Mind Beagle. You see here our intensive care, and the patient has this EEG cap, and we do the same thing. We ask questions and we look, decode the brain activity. We have a number of papers. This is again together with Cambridge and Western London, Ontario, where you see the Penfield activation. When we ask move your foot, it's more midline, move your hand, it's more lateral, and then you can decode it. And yes, we have patients where, big surprise, it's rare but existing, they can express their thoughts and wishes. And then, of course, we cross-correlate that with other neuroimaging tools. This is the Mind Beagle result, and when we have, you see covert response to command, meaning response to command that's only identifiable by neurotechnologies. We also see increased synaptic activity with glucose imaging. And that's having an impact. We have a number of patients. This is the first where Caroline Schneckers, at the time in Liège, and myself were asked for a second opinion in this young lady with a very extensive infratentorial brainstem hemorrhage, clinically comatose. Even if we opened manually the eyes and asked, look down, look up, nothing. We were really discussing, should we stop the respirator? Is this not therapeutic abstinency? And then we did this at the time own name active ERP study, where we asked the patient, well, you're going to hear a number of names. Every time it's your own name in the active condition. I want you to count the number of times you hear your name, important self-referential stimulus, and you see in pink that there's an increase in the P300, and that was all we got to say, well, wait a minute, this patient is hearing, understanding, and actually doing what we asked her to do, and then she subsequently recovered also. Of course, we continue the care, some motor activity. So it is making an impact. This was a case we published on a total locked-in syndrome, very rare, but existing. So let's sum this up. Patients with a severe traumatic brain injury or anoxia or hemorrhage or comatose, as soon as they open the eyes but only show reflex movements, we call them unresponsive wakefulness syndrome, previously coined persistent vegetative state. As soon as there's appropriate smiling, crying, emotional responses are very, very important, by the way, and often the first thing we have, so we should include family members when we do these assessments, or localization to noxious stimulation, or visual pursuit. We coin them MCS minus. The next big step is reproducible response to command, MCS plus. Now, what do we see with neuroimaging is that these two categories have a different functional neuroanatomy. So again, added value of neuroimaging. We see that those who fail to show response to command have left lateralized brain metabolic dysfunction encompassing the language network. And this is a big, big challenge because, of course, when patients have damage to the language network, they don't maybe understand the question. They are aphasic, and then we're in trouble because we can't say meaningful things about consciousness in the presence of aphasia. And of course, we have a challenge to have functional communication, even with the sophisticated brain-computer interfaces or the imagine playing tennis fMRI paradigm. So we've been investing a lot with the team in studies that do not require any understanding of language. And the most simple, basic thing one can do with functional MRI is just put the patient in the machine, hit the record button, and look at spontaneous brain activity. So we were very early adopters. We published very early on that this was meaningful. It was, again, completely broken down in brain death, and we see that there is some residual activity in minimally conscious state patients, very different from locked in or healthy controls, and then further breakdown in unresponsive wakefulness or so-called vegetative patients. And a critical hub is the precuneus there in the back, which is the cortical area with the highest number of functional connections, and that's the one that seems to separate MCS from unresponsive. So we're using these technologies, and to answer your question, yes, it does help us when faced to basically probabilistic diagnosis, because that's what we're facing in medicine. And we see a number of examples. This is another one, a patient with a brainstem lesion. You see there the white arrow showing to this pontine ischemia, and it was very challenging again, especially in the acute, subacute phase. Is this patient truly locked in or not? And then, of course, with fMRI, you see this residual activity in the consciousness network, and we were all ecstatic. Yes, we're seeing consciousness, but of course, we do not see consciousness directly. These are very rude and indirect measures, and we can get it wrong. It can be a Pinocchio. The images can lie. We can have false positives. And this is a big, big challenge, even more challenging than in other situations where, you know, you can study brain tumors and you have some gold standard. Let's do a biopsy, or even if it's difficult, let's look at autopsy, and you have a basic truth, which you don't have, of course, when you're looking for consciousness. It's not going to be visible on the autopsy. So this is a big, big challenge. We have both false positives. We think we see signs of consciousness with these functional imaging tools, but we can get it wrong. It can be artifacts coming from respiration, heartbeats, whatever, the machine. Or false negatives. We can conclude, well, there's nothing there in the testing, yet the patient can be conscious. We were just lacking the sensitivity to pick it up. So we've been studying with our partners, big groups, relatively big groups of disorders of consciousness, and cross-validating it with what we saw in anesthesia and using AI-based classifiers. And so this is a rapidly growing field where many centers worldwide now are adding to the understanding of what neuroimaging can do, and what I believe also should be known by the public and by lawyers, and is going to have an impact when faced with the challenging decisions judges and insurance companies need to make. So I've been discussing active paradigms, fMRI, ERP, and here another tool that is, I believe, very useful and also works in patients who are aphasic or completely paralyzed or have even sensory deficits, which is the perturbational complexity index calculation based on TMS, transcranial magnetic stimulation, coupled to simultaneous EEG recording. This is a difficult technique to do. It was first proposed by Marcello Massimini. You see him here on the picture in Belgium, in our center, doing this after he validated this in sleep. And actually, it is also collaboration with Giulio Tononi from Madison, who proposed the integrated information theory of consciousness, which basically says that for you to be conscious of something, the information needs to be integrated. And we here have a tool to quantify this capacity for the brain to generate consciousness. So basically you hit with this strong magnet, you perturb the brain and then read the electrical echo of that perturbation. And if it's very complex, to be a bit simple, there is the capacity of consciousness we see in locked-in patients in conscious controls. And then when we see this breakdown of complexity, similar as in sleep and anesthesia, we have the sign patients are truly vegetative or unresponsive and not minimally conscious. Okay, again, a very useful tool that is helping us clinicians, and I believe can be also useful in the setting of forensic medicine. Again, cross-validated with, as said, pharmacological loss of consciousness, where just one point I want to raise, consciousness really seems to critically depend on this widespread frontoparietal network, not on the sensory areas. You see here, both the visual cortex and the auditory cortex still show some functional connectivity. So they're necessary, but not sufficient. The next hypothesis that we tested is that awareness has two components. External sensory, what you hear and see right now, seems to critically depend on the lateral frontotemporal areas here colored in red. And then there's stimulus-independent thoughts that permit you to anticipate, you know, I'm now giving this webinar, but you're thinking about many other things, right? You need to answer that email, you need to do whatever, you're thinking about what happened in the past. That's this also called default modes, midline, mesiofrontal, anterior cingulate, and then posterior cingulate precuneus, colored in blue. We've shown in a number of studies, you see here one, again in healthy volunteers, in this case fMRI, they were just laying still, but the brain can't help it, it's thinking. And then we can ask people, well, were you more having sensory awareness, you know, the noise of the scanner? If they scored high, you see indeed that correlates with that in red. External network, if they were thinking about other stuff, so-called self-awareness, you see in blue the midline core. And it seems that they anti-correlate. So at any given moment, you switch from one to the other. We also showed that the activity in these networks correlate with perception. Paper in PNAS 2007 from Melanie Boli using sensory laser stimulation, or opposite the internal awareness network here correlating with perception of a self-referential stimulus such as the own name. So this seems to be you know, valid and can be applied to the clinical setting. And that's very important because, as said, at the bedside, we're kind of handicapped when we're just looking at motor behavior, knowing that consciousness, of course, is happening in the brain. And we've shown repeatedly that we can get it wrong into, you know, a significant portion of patients. There is more brain activity going on when we look at neuroimaging. We also showed that we not just need to emphasize the role of technology, which is the topic of today, but we should start by doing the best possible clinical exam. And this is a challenge. I've been involved in a number of legal cases, and then we have so-called experts who go into a room, do their exam, come out and say, okay, the patient is PVS, persistent vegetative state. Well, you cannot. You can be the most respectful professor you want. We've shown that, first of all, you need a validated scale. The most validated is the coma recovery scale, but I don't know how many of you use this. It takes time to learn this scale and to apply it. And very, very important, you need to see patients a number of times. We've published in Annals of Neurology, in 2017 that we should see patients at least 5 times. So very important in legal cases or when we want to reduce the uncertainty of the diagnosis based on bedside behavioral assessment, use a standardized scale and at least 5 times. And that's time consuming. This is why we proposed a new scale, which is the seconds. And that is the simplified evaluation of consciousness disorder scale. We published the guidelines and a video. You can find the references here. So this permits people with severe traumatic, anoxic, or whatever acquired brain damage or comatose to identify the first signs of minimally conscious state, MCS minus, MCS plus. And of course, this is the first thing we should do before we discuss the added value of neuroimaging, identify cognitive motor dissociation or MCS star patients. Again, we have repeatedly published and others that neuroimaging has added value. Hard to give a strong number here, but this is the Lancet paper from a couple of years ago on 130 patients sent to our center in Belgium, and neuroimaging showed in 32% information that was unavailable even with the best possible clinical assessment. We also showed, by the way, that 35% of patients had already a wrong diagnosis that we could deal with just with repeated standardized assessment. Okay, next is the challenge of prognosis. Patients who do show the signs of consciousness on neuroimaging are the ones who will subsequently have a bigger probability of recovery. So very, very important. When they do recover, we see thalamocortical reconnections. This is a very old paper in the Lancet 2000. You see here that the reconnections, and we could pinpoint the intralaminar thalamic nuclei, which led to the team of Nicholas Schiff in Cornell to put electrodes in there and to repeatedly publish that people with post-traumatic MCS can increase their consciousness and their quality of life through deep brain stimulation. We've, with the team, been investing a lot in non-invasive stimulation. There's a review in Lancet Neurology 2019 on all the different possibilities, including TDCS, transcranial direct current stimulation, but also pharmacological and other stimulations. Just focusing on TDCS, this is the work of Aurore Thibault and team. 2 electrodes, 2 milliampere, in a number of controlled clinical trials have been shown that this anodal left prefrontal stimulation can help patients with chronic disorders of consciousness. So again, the field is changing. I think the old dogma that had a very oversimplified and wrong view that some patients after coma recovered, but when they were in PVS, you know, it was basically waiting to die. Well, the idea that there's nothing we can do for none of these patients is wrong. We see neuroplasticity, that is the capacity of the brain to rewire, to adapt, and this, of course, is changing the field, especially for MCS patients. We should increase our efforts to identify them as soon as possible and to now translate these neuroscientific findings into better rehab. And I think neuromodulation is going to play a role, together with a number of other developments. I mentioned amantadine, zolpidem, the sleeping pill that rarely, but very impressive when it works, can awaken some patients. We also have Martin Monti using focused ultrasound treatment. We have RTMS, repeated transcranial magnetic stimulation. We have transcutaneous vagal nerve stimulation. And I mentioned already the pioneering work of Nicholas Schiff from Cornell, New York, on deep brain stimulation. So, in conclusion, I think there is definitely added value for neuroimaging when confronted to disorders of consciousness, where basically we want to say something meaningful about the capacity for consciousness and cognition, but we're limited at the bedside by making inferences based on motor responsiveness. So those people who survive coma open the eyes. The challenge is to find as soon as possible non-reflex behavior, which is heralding MCS minus. The next step in the question, is there awareness, is response to command. And we've seen the added value of brain-computer interfaces and functional neuroimaging with active paradigms that is permitting, in some rare but existing patients, a way for functional communication. So we're doing all of this to offer patients a better quality of life, which is very challenging. What it is like to be MCS, we don't know, but I think in the coming future, we'll be able to say more when giving these patients a voice through these technologies. In the meantime, we asked the question about locked-in syndrome patients. Again, you cannot be more handicapped than these patients, completely paralyzed, fed through gastrostomy. Many of them have a tracheostomy, so unable to speak. But through small movements of the eyes, they can answer the questions, how are you? From -5, worst period in your life, to +5, best period. This study we did with the French Association for Locked-in Syndrome in a quite big, relatively speaking, cohort of locked-in syndrome. This is what we got, +3, +5. So let's not judge a book on its cover. Yes, some of these patients, despite the severe motor handicap, can have a life worth living. There's also some of them you see answering -5, so we should also address the very challenging question. And in Belgium, we have allowed euthanasia, permitting people with locked-in to die. Just some final words also about the quality of life and the needs of their family members of disorders of consciousness. So we, together with Olivia Gossery, recently published the Quality Needs Survey. And I think the results are just shockingly bad. People sharing with us that they need medical information. This is the most important in 99% of them. And when we ask, is they satisfied? Only 29%, as you can see on the graph, is saying yes, this important need is satisfied. The same for involvement in care, social and emotional support. So definitely there's room for improvement. And I hope as a community, and the International Brain Injury Association is definitely, together with the working groups and the very hard work of not only you, Nathan, but also Karen Schneckers, translating everything we are discussing into better clinical care. And it matters, of course, for many reasons. We mentioned improved prognosis, we mentioned the increase in rehab efforts, but also, of course, the capacity of these patients to perceive pain. I started this webinar with the question, what is it, like for this rat when I study pain, because can't communicate. It's the same for the coma patients. They can't communicate, and yet the brain imaging shows that they do feel pain, and we should treat accordingly. So in conclusion, we are witnessing fascinating times where it is clear now that there is, in a number of these patients, the capacity for recovery. Neuroimaging is showing it, and I'm very happy to work with a number of centers also proposing robotics in the rehabilitation of disorders of consciousness coupled to neuromodulation. For those who are interested, I did a TEDx on concussion and post-concussion syndrome. This is also one of the reasons I'm now in Canada, because there's a lot of sport-related brain injuries, but we will leave that for another talk. I thank you very much for your attention, and just wanted to conclude. Of course, I thank the team, I thank the patients and their families, and that's why I created MindCare. And for those who are interested in publishing their work, I'm now the editor-in-chief of Brain Connectivity. So please reach out for further information. And I hope, Nathan, we have time for questions if there are any.
Yes, we should have several minutes. Thank you for that excellent talk, Stephen. I don't see anything in the chat. If you have questions, please submit to the chat box. I'm going to go ahead and ask you a question. As someone who does medical legal work, at least in the States, we often have the conundrum of being given one shot, so to speak, at evaluating someone in the context of doing a so-called independent medical examination for medical legal opinions. And I have written on this actually recently in the issue of neuro rehab that Carolyn Schnakers and I did on DOC, and emphasized what you also spoke about in your talk about the need to do serial assessments. In the context of medical legal / clinical work, do you have any suggestions when the court system is such that it may limit your ability to do serial examinations? How much would you either refuse to do the assessment in that context or advocate for what science tells us about the need for serial assessments? Do you have any suggestions?
Thanks, Nathan, for that. I think we should really share the current scientific understanding that what is, you know, characteristic of these patients with minimally conscious state is that they fluctuate. So this is different than assessing someone with a broken arm or something, or
Right.
you can look at this and give your appreciation. So it's important we share that studies show that we should see them a number of times. That's why I believe that the basis, which is still the bedside assessment, and I've been talking about the seconds, which is easy to learn and to do. So the philosophy is to do less more. And then in terms of the neuroimaging, it's tricky. And I also see Anna Estraneo asking the question, what is the role of neurophysiology and EEG? Well, definitely it's important, and we should take everything we possibly can to help us reduce the uncertainty. And some of these tests depend on fluctuations in patient state. So if the patient is less aroused, and we've shown that they do show using indeed long duration EEG recordings, they have moments where their arousal and hence awareness is very low. And if we assess them at that moment in time, we will miss things. So this is terribly challenging. So of course, I'm in a luxury position that in these expert centers, we can do structural MRI and fMRI and FDG PET and EEG. And I understand that this is not possible everywhere. If I would need, to pick one, of course, MRI, I think, is still quite available. And we're trying to show that there's a lot of information in high resolution T1 structural imaging and again, automated assessment using voxel-based morphometry, for example. There's a lot of information in structural DTI imaging, giving us a sense of the white matter integrity. Because the fMRI, the functional tests, is the same for EEG. It depends at what moment in time and the importance of possible confounders. The drugs people take, anti-epileptics, can make them more sleepy. The antispasticity treatment can make them more sleepy. I think FDG PET is the one that I would appreciate most, but it's terribly hard to get because it's mostly cancer patients, it's long waiting list, and these patients who can't collaborate, it takes a lot of time and hence money. But still, I see more and more patients where they ask my second opinion, and I can discuss with the local nuclear medicine department and say, okay, this is the way we do the FDG PET, and you can send us the data. This is the way we do it. And that is the most direct marker of synaptic activity that would even work in patients who are agitated, that we would need to sedate, where of course then the EEG is ruined, the fMRI is ruined. And here we can basically look back in time. So we inject the glucose, and then after 30 minutes, it's fixated in the brain, and we can do the anesthesia and still have very informative neuroimaging. I hope that answers your question, Nathan.
Yes, I think you answered mine and a couple of others on there. I think we have time for one more question because we do need to end at 1. I think the DTI issue was addressed more or less. There was another question for less compromised individuals. What do you think about functional EEG for cognitive assessment, such as Vox Neuro at McMaster?
Yeah, very, very specific question. For those who emerge from MCS and can functionally communicate, I would like first to discuss the role of the neuropsychological testing. That sometimes is not adapted to these patients, because we have patients with limited attention spans, with a number of cognitive memory impairments. So I would like to see more efforts to adapt our cognitive tests to the challenges of patients with disorders of consciousness who are emerging. And then, yes, as you mentioned, there's a number. I'm not going to say one is better than the other, but yes, we can use functional EEG, but still together with the expertise of the neuropsychologists doing the adaptive testing.
All right. On that note, I would like to thank you again for the wonderful talk and for sharing your expertise. It was good seeing you. It's been a while, so hopefully it won't be as long for the next time. Hope everyone enjoyed the webinar, and please keep your eyes out for future webinars from IBIA. Everyone have a good day. Thank you again, Dr. Laureys.
Thank you so much. Thanks for being here. Bye, Nathan.
Bye-bye.
Cheers.